Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 218 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the next question reads, what is the most common cause of viral myocarditis? Is it A. Cytomegalovirus, or B. Enteroviruses, or C. human herpes virus 6, or D. influenza A, or is it E. parvovirus B19? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Enteroviruses. I will clarify why. The most common cause of viral myocarditis is enteroviral infection, including infection with Coxsackie virus A and B and also echovirus. Numerous other viral pathogens have been implicated in cases of viral myocarditis, including all of the other options listed, and many others. Please progress to the next question. And the next question reads, T.K.L., a 23-year-old man from Mexico is admitted to the hospital with 2 months of cough, night sweats, progressive shortness of breath and pleuritic chest pain. T.K.L's chest CT is shown below. Subsequent echocardiography suggested early tamponade physiology. A pericardial window was performed and necrotizing granulomas were seen on pathology. Pericardial fluid adenosine deaminase level was elevated but fluid cultures are negative. Pause the video and carefully scrutinize T.K.L's chest CT before proceeding to the next slide. So my question to you is, what medical therapy would you recommend for T.K.L's clinical scenario? Would it be A. colchicine, or B. indomethacin, or C. prednisone, or D. rifampin, isoniazid, pyrazinamide, and ethambutol, or E. rifampin, isoniazid, pyrazinamide, ethambutol, and prednisone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. rifampin, isoniazid, pyrazinamide, ethambutol, and prednisone. I will explain why. Tuberculosis is an important cause of pericarditis, but achieving a definitive diagnosis can be challenging. The tuberculin skin test may be negative and patients may not have active pulmonary symptoms or positive sputum cultures. Elevated adenosine to aminase levels in the pericardial fluid and granulomatous inflammation in the pericardial tissue are supportive. Definitive diagnosis necessitates demonstration of Mycobacterium tuberculosis in pericardial fluid and/or tissue, but culture sensitivity depends heavily on sampling and burden of infection. Empiric therapy may need to be instituted based on a presumptive diagnosis. In cases of tuberculous pericarditis, adjunctive therapy with corticosteroids has been shown to improve outcomes. Please proceed to the next question. And the next question reads, BMW, a 65-year-old woman is admitted with Enterococcus faecalis bacteremia after a recent episode of diverticulitis. BMW's echocardiography shows vegetations on her aortic valve. The bacterial isolate is susceptible to all of the agents tested and she has normal renal function. Of the options listed below, which is the least appropriate antimicrobial regimen for BMW's case? Is it A. ampicillin and gentamicin, or B. ceftriaxone and ampicillin, or C. penicillin and gentamicin, or D. vancomycin, or is it E. vancomycin and gentamicin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. vancomycin. I will explain why. Treatment regimens for enterococcal endocarditis should be guided based on susceptibility testing, and if possible, combination therapy is preferred. For beta-lactam and gentamicin susceptible strains, a combination of either penicillin G or ampicillin with gentamicin is recommended. In penicillin-allergic patients, vancomycin, in combination with gentamicin is recommended. In patients who cannot tolerate vancomycin or in those with renal dysfunction that precludes use of an aminoglycoside, a combination of ceftriaxone and ampicillin has been used with success. Please advance to the next question. And the next question reads, TJP, a 19-year-old girl presents with a week of thin, malodorous vaginal discharge. A pelvic examination was performed and TJP had no evident cervicitis. TJP's vaginal pH was 7. Light microscopy examination of the discharge showed abundant clue cells. So my question to you is, what is the most appropriate antimicrobial therapy for TJP? Is it A. azithromycin, or B. ceftriaxone, or C. doxycycline, or D. metronidazole, or is it E. penicillin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. metronidazole. I will clarify why. Bacterial vaginosis can be associated with thin, adherent vaginal discharge, elevated vaginal pH, positive amine test and presence of clue cells on light microscopy. Metronidazole or T-nidazole are the most commonly prescribed antimicrobial agents in this clinical scenario. Please advance to the next question. And the next question reads, Q.P.D, a 26-year-old female is diagnosed with gonorrhea cervicitis. So my question to you is, what antibiotic treatment is recommended for Q.P.D? Is it A. azithromycin, or B. cefixime, or C. ceftriaxone, or D. ceftriaxone plus azithromycin, or is it E. doxycycline? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. ceftriaxone plus azithromycin. I will explain why. Combination therapy with ceftriaxone and azithromycin is the preferred regimen for treatment of uncomplicated gonorrhea cervicitis, both because of increasing rates of antibiotic resistance and to provide coverage for possible concomitant chlamydia. Please proceed to the next question. And the next question reads, B.Z.K, a 19-year-old man with HIV presents to clinic with a new onset rash. His RPR was 1 to 16 and his FTA-ABS was positive. B.Z.K's RPR was checked 6 months ago, and at that time was non-reactive. Pause the video and carefully scrutinize the photo before advancing to the next slide. So my question to you is, what is the most appropriate antibiotic treatment for B.Z.K? Is it A. azithromycin dosed at 2 grams, stat. Or B. ceftriaxone dosed at 250 mg IM, stat. Or C. doxycycline dosed at 100 mg orally twice daily for 2 weeks. Or D. penicillin G dosed at 2.4 million units IM, stat. Or is it E. penicillin G dosed at 2.4 million units IM, weekly, for 3 doses? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. penicillin G dosed at 2.4 million units IM, stat. I will justify why. B.Z.K has early secondary syphilis, as manifested by the diffuse, morbilliform rash and RPR conversion in less than a 6-month period. The recommended treatment is 1 IM dose of penicillin G. On the other hand, doxycycline for 2 weeks or azithromycin can be considered as alternative regimens. 3 doses of IM penicillin G would be appropriate for latent syphilis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 219.